I'd like to start by thanking Dr. Scott as well as my mentor, Dr. Coker, for the opportunity to present. Today I'll be discussing the relative contribution of hospital and health market factors to variation in emergency department hospitalization practices among Medicare beneficiaries. I have no conflicts of interest to disclose. Dr. Coker just disclosed that he's supported by the Career Development Award as well as he acts as the program director for Medic. So I would like to start by just highlighting the context in which our research question was developed. There have been nearly 4 decades of work demonstrating variations in nearly every aspect of how healthcare is delivered in the United States. Variations in outcome were initially thought to be consequent just to patient-level factors such as medical comorbidities. However, conceptual models have increasingly demonstrated the multitude of social determinants of health. Improved data collection and advancements in risk adjustment have demonstrated time and time again that variations in outcomes are attributable to more than individual patient-level constitutional factors. And so why does all of this matter? So we all know that the cost of healthcare is becoming increasingly unsustainable, consuming approximately 20% of GDP. We are operating on the flat of the curve with regards to cost and derived health benefits. The impetus for driving a higher value health system has never been a greater priority. We are increasingly being asked to provide higher value healthcare at a lower cost to more people. Emergency medicine is on the front lines. We have assumed a critical role. We are in charge of making one of the most costly and consequential decisions in our healthcare system, the decision to pursue admission. Emergency providers make this determination 400,000 times a day in 5,000 emergency departments, resulting in 20 million annual admissions. The impact of this decision is being amplified by recent trends. From 1993 to 2006, the overall number of hospital admissions increased by 15%, whereas admissions from the emergency department during that same time frame increased by 50.4%. The decision to pursue admission demands judgment about the marginal benefit of inpatient care. We experience variations in decisions to pursue hospitalization on a daily basis. Understanding variation in admissions decisions is essential to provide targets for interventions and value-based benchmarks for providers and policymakers to improve the efficiency of acute care delivery. So in our study, we sought to describe variations in emergency department-based hospital admissions in the context of patient, hospital, and hospital referral region characteristics. The second component of the analysis aimed to assess the relative contribution, after adjusting for patient factors, of the hospital and health market factors on emergency department-based risk standardized hospitalization rates. So how did we seek to study this research objective? Emergency department visits were identified in a 20% sample fee-for-service Medicare administrative claims data set and were characterized by disposition. We then designed a 3-level hierarchical logistic regression model of patients nested within hospitals, patients nested within hospitals, nested within hospital referral regions. We then employed a median odds ratio to describe the relative influence of hospital and hospital referral region characteristics on emergency department risk standardized hospitalization determinations. So what did we find? So there is significant observed variation in emergency department hospitalization practices. And even after you adjust for case mix, significant variation persists. So what accounts for this? Let us look at variation in patient, hospital, and hospital referral region characteristics within the hospitalization profiles. At the patient level, there are expected variations. Older patients and those with more comorbidities were more likely to be hospitalized. Understanding hospital characteristics is also very important, given the fact that supply-sensitive care or that the supply of a resource has a major influence on utilization rates accounts for more than half of all Medicare spending. Interestingly, Teaching hospitals and those with greater annual ED visit volume had lower emergency department hospitalization rates. And hospitals with less beds were more likely to have high ED hospitalization rates, whereas those with more beds were likely to have lower ED hospitalization rates. Further, hospitals with higher technological access had lower emergency department hospitalization rates. So while on shift, we all know that our admissions decisions are frequently impacted by consideration of factors outside of the wall of our hospital. For example, will this patient be able to see their primary care provider for reevaluation within the next several days? Local healthcare market factors do impact our admissions decisions. We examined metrics to comprehend supply, access, and quality at the hospital referral region level. Interestingly, hospital referral regions where more primary care providers, or with more primary care providers, were more likely to have higher hospitalization rates. And these areas of higher hospitalization rates had a higher percent of their Medicare beneficiaries that were seen by their primary care provider within 14 days of hospital discharge. But we found that areas where there were more annual office visits were more likely to have lower emergency department hospitalization rates. We then sought to quantify the contextual dimension of variation in hospitalization practices from the emergency department, and found that after adjusting for patient, hospital, as well as hospital referral region characteristics, both hospital and hospital referral regions both impacted the admission decision. However, hospital characteristics had a greater impact. So all of these findings have to be interpreted within the limitations of our study design. So using administrative claims data set, you lack the granularity of provider level influence. Our covariates definitely did not comprehend all of local healthcare market factors. And the use of administrative claims data set for the measurement of ED admissions and risk standardization have not been validated in comparison to clinical review of medical records. Our analysis was limited to the Medicare claims data and therefore might not be generalizable. And so in summary, we found that significant variation exists despite adjusting for case mix. There are variations in patient, hospital, and hospital referral region characteristics related to hospitalization profiles. Both the hospital and the hospital referral region characteristics influenced admissions decisions, but hospital characteristics had a greater impact. So what does this mean for us moving forward? So policymakers frequently depict the emergency department as a locus of inefficient, unnecessary, high-cost care. However, in an era that's promoting high-value healthcare and financial incentives to improve efficiency, hospitals and policymakers are seeking tools to examine hospital admissions to drive improved alignment between expenditure and the marginal health benefit of admission. Emergency medicine is poised as a very influential stakeholder. Variations in emergency department-based hospital admissions decisions should be viewed as opportunities for quality improvement. Let's identify the outliers and let's emulate best practices at high-performing centers. Our research highlights that interventions targeting hospital admissions will be imperative, but that investments in outpatient and social services should also be considered when striving to reduce cost and variations in emergency department-based hospital admissions. Our unique role has rendered us leading innovators in our health system, as clearly demonstrated by all of the presentations that have preceded. We have an emergency department-based critical care unit, alleviating the strained inpatient capacity of ICUs. We have generated clinical care pathways embracing alternatives to admission, and are incorporating risk stratification tools to actively promote appropriate utilization of resources. Through MEDIC, we are embracing the next paradigm of collaboration as the new competition, rendering collaborative quality initiatives a reality in emergency care delivery, and creating a foundation from which to be leaders in driving high-value care at a regional level. At Michigan, we truly are at the leading edge of clinical medicine, research, and implementation science. I would like to thank the constituents of our team, and I would like to open for any questions.
Fantastic presentation, and this is really an important area that we need to embrace as a specialty. One of the considerations that a lot of people have in mind in the decision to admit is the litigation environment of where the practice is. Have you guys thought about incorporating that into as one of your variables?
Yes, no, I think within the limitations of the data sets that we had access to, not something that we were able to accurately kind of incorporate into the model. But I think when you start to have opportunities such as, Medic, when you really assess more of like the provider level determinations, I think you might be able to get more of the medical legal impact of the admissions considerations. And I think it would be a very interesting step moving forward. All right, thank you very much.